So we are going live in 3, 2, 1. We are live now.
Just a minute. So my screen is froze. Just a minute. Yes, now we can start.
So shall we start? Joseph sir?
Yes. Please go ahead.
Thank you. Good evening, friends. Warm welcome to the 10th episode of Blood and the Life Savior. Knowledge feast for all the physician and the hematologist. This platform brings together young mind and experienced hematologists and the rare cases for deep learning and discussion. This evening session is brought to you in collaboration with the PGI Chandigarh, Dr. Arihant Jain and their team. We extend our sincere thanks to their team for making this possible. It's an honor and privilege to introduce the two pillars of the blood, the life savior. Our respected course director, Dr. Biju George sir and Dr. Joseph John sir. Dr. Biju George sir, he is a professor, Department of Clinical Hematology, CMC Law. And sir is having a lot of publication, more than 296 publication, and the prestigious award and the international publications are there. And moreover, contributed in the 6 book chapters and publications and achievement development. So sir has initiated over 200 hepatoidentical transplants at the CMC Vellore and developed the specialized transplant protocol for the other indications also, and area of interest is stem cells, transplantation and infection management, and bone marrow failure and disorders are there. And further to this, our second pillar, Dr. Joseph Jones, sir, is a professor and head of Department of Clinical Hematology, CMC Ludhiana. Sir is having more than 30 international and 30 national publications and part of 7 books in the prestigious national and international publications, and 1 copyright protocol is also there, and principal investigator in more than 20 clinical trials are there. So key contributions, sir has established the clinical hematology and the stem cells transplant service at CMC Ludhiana in 2008 and founded Comprehensive Hemophilia Care Center and at a Center of Excellence in 2010 and pioneered the first successful stem cell transplant for leukemia in Punjab and launched the DM program in clinical hematology in 2019 and innovated service like home care and mobile pathology is also there. So I'll not take much of the time and hand over the session to Dr. Joseph Jones, sir. Sir, please, you can take it from there, sir.
Thank you, Arun, and thank you, Diksha, for organizing this. And I guess with so many participants across the country, this has proved to be fruitful because the entire world is talking about cancers mostly, and that it is a fresh breath of air with the benign hematology, which we see in OPDs mostly. It's my privilege to invite and introduce Dr. Arihant Jain, who's an additional professor at PGIMR Chandigarh. He has a special interest in hemophilia, thrombosis, stem cell transplant, and hematological malignancies. He will be introducing his team, and we will straight dive into the case and try to understand what is unique in this case and what we can take from. Over to Dr. Arihant.
So, thank you, the organizers, and thank you, Joseph John sir, for kind of introducing this learning interactive session in the classical or benign hematology field. And thank you for the kind introduction as well. So, without further delay, I would now like to request Dr. Naman Lodha, who is our youngest in the team members in the clinical hematology, senior resident in the Department of Hematology, who would negotiate us through an interesting case. Over to you, Naman.
Good morning, sir. My name is Dr. Naman, senior resident in PGI, as told by sir. Shall I begin the presentation?
Yes, yes. And we also have Dr. Sarthak, who is our post DM clinical hematology research associate. And besides transplantation and myeloid malignancies, he also has special interests in immune thrombocytopenia. So he will be the supervising commentator for this case. Naman, you can start the case.
Should I start the presentation? Yes, sir.
Yeah, yeah.
Is the presentation being visible?
Not yet,
Yes,
sir.
Not. 1 minute.
Yeah, now it's visible.
It's visible.
Yes,
Yes.
sir, it's visible.
So today's in our presentation, the topic is discordant clues, autoimmune myelofibrosis, and cytopenias mimicking tephrospectrum. So we had a case, Miss G, 33 years old female, resident of Patna, Bihar, housewife, who presented with chief complaints of joint pains since 1 year, low-grade fever since last 2 months before presentation, shortness of breath, MMRC grade 3, which was on exertion mainly since last 2 months, epistaxis on and off since 2 months, pedal edema since 2 months. Initially, in December 2024, she was reviewing in an outside clinic for her musculoskeletal symptoms, where under suspicion of rheumatoid arthritis, she was started on methotrexate. In further evaluation, in view of non-improvement, subcutaneous methotrexate was later administered. However, patient had no response. Further, patient came to PGI for further workup. Patient had no history of abdominal pain, burning in micturition, cough, malar rash, photosensitivity, oral ulcers, Raynaud's phenomena, Zika symptoms, or pregnancy loss. Past history was not significant. She had normal menstrual cycle, regular monthly cycles. Family history was not significant of any hematological disorder. Personal history was normal. No history of any chem intake was present. On examination, patient had high blood pressures, that is 160 by 80. Pulse rate was 120, high volume regular. Saturation was, she was maintaining a saturation of 96% on 2 liter oxygen. Her respiratory rate was 24 per minute. On general physical examination, pallor and bilateral pitting pedal edema up to ankles were present. On respiratory examination, bilateral up to mid-scapular region, decreased air entry was present. CVS and per abdominal and CNS examination were normal. Baseline investigation showed a low HB, TLC were reduced, 3670, platelets were 7000, total bill was normal, total proteins was 6.47 with hypergammaglobulinemia present, albumin was 1.75, raised LDH, normal creatinine, and normal all viral markers were negative. So we evaluated for the underlying anemia and comparatively pancytopenia, anemia, leukopenia, and thrombocytopenia. Her T-set was 31.4%, ferritin was 1344, retic was low, 0.33 corrected retic, B12 and folate were normal, LDH was raised 744, and a low heptoglobin. Her urine microscopy showed 3 plus protein urea and blood 3 plus present. Urine for active sediment showed RBC cast present. 24-hour urinary protein was raised. That was 1737 mg per deciliter. PBF showed mild anisopoikilocytosis with eleptocytes and teardrop cells being present. Platelets were markedly reduced. ANC was 1544, ARC was 19400. So this was the PBF picture with sparsely distributed RBCs and a low platelet count. So initially, in view of suspicion of fever, evaluation blood cultures, paired culture was sterile, urine cultures showed no growth, a raised ESR was present, CRP was like fluctuated between 14 to 18 during the hospital course, Procal was 0.761 baseline, dengue infection, HIV was negative. So considering the presence of pancytopenia, um, coagulation workup was also sent that showed normal PT, APTT, fibrinogen levels. Uh, considering the pancytopenia with a low retic count, bone marrow and PBF showing mild NSApoikilocytosis with reduced platelets and leukopenia, a bone marrow aspiration was done, which showed aspirate were hemodiluted. However, in the imprints, the thrombopoiesis was reduced, granulopoiesis were normal, erythropoiesis was normoblastic to megaloblastic, no ring sideroblasts were seen. Trephine biopsy showed presence of an hypercellular marrow with an overall cellularity of 70 to 75%. Granulocytic hyperplasia was there. Megakaryocytes were mildly increased in number. A single nodular aggregate of reactive lymphocytes was seen. Background, there was present of fibrosis in a paratrabecular and interstitial location. Reticulin staining was 3 plus. So we had this part as seen in this bone marrow image, gross reticulin fibrosis was present. So considering the basic workup of myelin fibrosis, a molecular studies was ordered. So in molecular studies, BCR-ABL was negative, JAK2 was negative, KLR mutation was negative, MPL also negative. So we send an NGS myeloid panel to look for other mutations related to MDS being present, which showed no pathogenic variant. Fish panel for MDS was also done, which showed normal fish results. No evidence of 5q, 7q deletion. Trisomy and 20q deletion was also absent. So, flow cytometry also confirmed no abnormal B or T cells being present. So, considering joint pains, presence of underlying myelofibrosis, uh, further evaluation to look for autoimmune part, we sent ANA for the patient, which showed 4 plus homogeneous pattern. Anti-DS DNA was also sent, which came out to be positive, 537. ANA blot showed dsDNA 2 plus, anti-SM2 2 plus, nucleosome 2 plus positive. Complements were low. Other aspect of autoimmune part, rheumatoid factor, anti-CCP, C-ANCA, P-ANCA were all negative. DCT showed anti-IgG 3 plus, anti-C3D was negative. So, a CT was also being done. It showed CT showed bilateral pleural effusion, no evidence of pulmonary thromboembolism, enlarged subcarinal left para-aortic and bilateral iliac lymph nodes with preserved fatty alum. No organomegaly was denoted as per CT. Liver span was 15 centimeter and spleen size was around 12 centimeter, 12.9 centimeter. Maximum lymph node size was 1.2 centimeter in left para-aortic region. It showed preserved fatty hilum being present. So considering two possibility, considering so we had the following. So with respect to reticulin fibrosis, I want Dr. Sarthak to further elaborate the treatment of the diagnostic approach for the further evaluation of underlying case.
So, as this patient came to us after evaluation of pancytopenia with a low retic count, a bone marrow was done initially from the referring unit. And on bone marrow, the predominant feature, as discussed by Dr. Naman, was presence of reticulin fibrosis along with increased megakaryocytes, mild megakaryocytic hyperplasia. If for reticulin fibrosis, the common differentials which come to our minds are MPN neoplasms, the whole MPN group, whether it is MF, PV, or ET, the usual autoimmune or connective tissue disorders, a Tafro-Castleman mixed picture. Also, the other possible causes were infections, granulomatous diseases, and other hematolymphoid malignancies such as leukemias. Also, they can cause mild reticular fibrosis. So, because all the other etiologies were ruled out, there was no. We took three etiologies into consideration. The number one etiology was primary myelofibrosis, but even more commoner than primary myelofibrosis, considering the age, absence of any splenomegaly, and a rather subacute onset of cytopenias, we considered either an autoimmune myelofibrosis or a Tafro syndrome like picture. So, as the patient did not have any clinical classical features of any autoimmune disorder, but she did have positive ANA with dsDNA and low complements, along with the nephrotic range proteinuria and presence of RBC casts on urine microscopy. So this patient fulfilled the criteria of SLE. And along with SLE, the autoimmune myelofibrosis can be seen, which can have mild megakaryocytic hyperplasia along with it. So we labeled the cytopenias to be rather an immune cytopenias, and we also ruled out primary myelofibrosis by absent initial molecular panel by three mutations, which were JAK, ET, and CALR, and also an extended full spectrum NGS myeloid mutation panel. The other Crow's differential was Tafro syndrome because of the classical picture of Tafro, such as thrombocytopenia, anasarca, fever, and presence of renal dysfunction along with reticular myelofibrosis. But the background picture of SLE and any absence of Castleman syndrome, absence of normal IL-6 levels were more in favor of autoimmune myelofibrosis secondary to SLE along with renal involvement. So handing over to Dr. Narman again.
So during hospital course, patient was managed symptomatically with 2 PRBC transfusions, 12 RDP transfusion, albumin supplementation for 5 days, MPS pulse was given for 3 days, prednisolone was given 60 mg, followed which patient was shifted on oral prednisolone. Rituximab was given 375 mg per meter square on 29/7/25. HCQ was started. Okay, so during admission, patient had hemoglobin of 5.6, baseline 7,000. Patient was given 4 doses of rituximab at the rate of 375 mg per meter square with a tapering steroids. So gradually, patient platelet count started to improve and reached the and finally reached the 225 Ka. Also, patient had decrease in 24-hour urine protein from, as you can see, from 1737 mg per day to 250 mg per day. Hemoglobin also gradually improved without any need of further transfusion support. So in OPD follow-up, gradually tapered, prednisolone was gradually tapered. Rituximab was continued for 3 more doses at 75 mg per 375 mg per meter square. HCQ was continued. So this was the platelet trend. Finally, we kept the diagnosis as SLE with autoimmune myelofibrosis. SLE manifestations were musculoskeletal, DCT3 positivity, hypocomplementemia, elevated dsDNA level, query lupus nephritis. However, we can't do biopsy at that stage because of underlying cytopenias. Also, we didn't did any lymph node biopsy for the 1.2 centimeter para-aortic lymph node because of underlying thrombocytopenia. So we kept the diagnosed query lupus nephritis, and also because it responded to rituximab regimen, stage 4 to 5. So handing over to Dr. Aryan sir for further elaborating.
So thank you, Dr. Sarthak and Dr. Naman. So I think although in the presentation it looks simple, but obviously when the patient is sick on oxygen, like this patient was severely anemic, and so the first report which came to us was actually just a marrow report, because that was done on an outpatient basis by the referring unit, and that had shown reticulin of 3 plus. But the patient did smell of an inflammatory cytokine which was going on, and there was so why we thought that we would discuss this case on this forum is that we wanted to highlight that one thing is that fibrosis in the marrow can have a varied etiology, although we all, at least as hematologists, tend to think about myeloproliferative neoplasms and MPN related myelofibrosis as the commonest disorder. But if you have a young age, if you have a rapidly progressive cytopenia, a short history, and the spleen, which is not impressive, those are actually the kind of pointers or clinical pearls which where you should actually be thinking of other alternative causes, of which autoimmune disorders are one of the commonest which need to be ruled out, and the treatment paradigm is completely different. So that is one take home from this case, that not all myelofibrosis is equal to MPN. The second, so basically we decided on pulse corticosteroids in this case even before our ANA reports had come back. So because it felt like an in the background of an arthritis kind of illness, it did smell of a autoimmune disorder. And even before the platelets, even before the ANA and dsDNA reports came, the actually the patient had already started improving. So what was odd for a Evans kind of a syndrome was that the initial retic counts were low. So the other thing which we need to understand is that not all hemolytic anemias, particularly in the Indian scenario, may have a high reticulocyte count. So this patient was actually from not a, she was not from a what I would say, she was not nutritionally well built, and so there were certain nutritional deficiencies which might have contributed to reticulocytopenia, or in 10 to 20% of the cases, even in autoimmune hemolytic anemia Evans spectrum, we do have anti-reticulocyte antibodies which are there, and in those cases DCT may come to be negative. So that's the second take home, that autoimmune, even anemia or AIHA, may not be always uh, uh, present with a high reticulocyte count. So that is one thing which we should be aware of. Although it is rare, but it's possible. So that's the second point. The third point is that I still believe that this patient does fulfill the criteria of a Tafro syndrome. This is a recently described entity from 2010 and onwards. This is being described, initially described from the Japanese colleagues, and this patient had all manifestations. She had thrombocytopenia, she had anemia, she had renal failure or reticular fibrosis. So as organomegaly is one, if we take hepatomegaly to be significant, that was there. So again, the treatment is kind, and Tafro syndrome can be associated with a Castleman-like histopathology, and sometimes if the nodes are difficult to sample, you may or may not demonstrate that. So, and again, a lot of time uh, anti-IL-6 therapies may be uh, considered, but if it is associated with SLE like manifestations, then rituximab and steroids are also one of the treatment modalities which can be utilized. So this patient, although currently she has improved better, but because she is SLE and she did have a significant, which had a predominant hematological and renal manifestation, and rituximab is now being increasingly used as a preferred agent. So but I believe that this patient would need to be on a close follow-up, and maybe she would need certain steroid sparing agent such as azathioprine or MMF in near future. So those were the summary points from my end, and we are open to questions and discussions, and maybe Joseph sir, if you have any special
Yeah.
back. Thank you.
So while the questions are populated in chat box, I'll start with Naman. There was no spleen, or there was some splenomegaly? I missed that
No
point.
spleen. No
No
spleen.
spleen. Okay. So, from the point of view, I'm just saying as a clinical this thing, when you are saying pancytopenia, no spleen, at that point, wouldn't HLH also should, I mean, I'm sure you would have considered an HLH, but nothing was in the marrow, and assume that there was no HLH features upfront. I'm just saying at that point, for any student who's listening, pancytopenia with high fever. Yeah, Aryan, go ahead.
Yeah, sir. Thank you for kind of highlighting that point. Yes, HLH, EVANS, ALPS-like syndromes, those are again, and even in our, particularly this time of the year, even the commoner infection-related etiologies one needs to. So sometimes dengue may present very much like this.
Correct.
So all those things need to
You
be
probably
considered.
look through.
Uh,
Sarcoidosis, considering the mediastinal nodes, could that have been a possibility?
No
Yes, sir,
mediastinal
even
was
that is, although this patient's course was very rapid, so short history and rapid decline, became quite sick, not very significant interstitial fibrosis, which was there. So MAS is, I think, macrophage activation syndrome in the setting of SLE is still somewhere, given the hyperferritinemia, we should actually
You should consider.
say that it was.
Marrow not having, hemophagocytis would have been the only negative points again. This others would have been high on the target with the cellular marrow with no count, low counts there. The
Yes.
other question I had was, his 24-hour erythropoietin is high, and Staphylo syndrome, I understand, is somewhere around the Castleman, is what you mentioned. How do you make, this is a constellation of symptoms of Staphylo,
Yeah.
but how on pathology you would say it is a Castleman? What are the telltale signs for us to take home? Even for me, it is new. It's good to, we would have probably labeled him an immune phenomenon and, treated with that. And I would have wanted to know the vitamin D3, and was vitamin D3 done on him?
Naman, even I don't recall, did we?
Okay, so that sometimes that can be a cause for fibrosis, but otherwise, I want to understand from pathologists, how would you make a diagnosis other than the constellation of symptoms? Of course, autoimmunity, SLE features you mentioned. Is there anything to say? So why is it called Castleman? I'm not able to understand that also.
So, good morning, sir. Good evening, sir. In patients with suspected Tafro syndrome, like usually we need a Castleman disease or lymph node disorder, a lymph node biopsy-based diagnosis. But however, there is written, like in patients with Tafro syndrome, usually they don't have that much enlarged lymph nodes, basically, first point. And if you don't have a diagnosis based on biopsy basis, because in Tafro, usually you deal with thrombocytopenia. T stands for thrombocytopenia. If you can't get a biopsy being done, and you have underlying high suspicion of being Tafro syndrome, you can start treating him.
Sure. So you are saying that if we had done a biopsy, we would have found some Castleman features.
Yes, sir.
Otherwise,
If
in the
we
Sartak
suspect,
has.
considering this case as a suspected Tafro syndrome initially, though we don't find high interleukin levels, but the diagnostic criteria of Tafro syndrome says underlying presence of an anasarca, as a presence of underlying pleural effusion. Organomegalies, even though they are mild, presence of a lymphadenopathy, 1.3 centimeter para-aortic lymph node, a high CRP level more than 2 will be considered as a diagnostic criteria of a Tafro syndrome, even though biopsy can't be done.
Yeah, no
But
problem.
we
I'm
have
just
to
trying to say
exclude
every time it's not
other
possible.
causes.
Yeah, I agree
Yes,
with
sir.
you. It's not possible all the time. Yeah, Sarthak wanted to say something. You're muted, Sarthak. Yeah, unmute.
Yes. So in cases
Yeah.
where we are not able to do a lymph node biopsy to prove that there is a Castleman etiology behind it, a kidney biopsy would have easily differentiated the two etiologies, whether it is Tafro syndrome or whether it is a lupus nephritis-like picture. We could not do it
Okay.
here because of the severity of thrombocytopenia was there. But in cases of Tafro syndrome, the usual things which seen on kidney biopsy are classically glomerular endotheliopathy. There is loosening of glomerular cells, and there is also expansion of subendothelial space. Along with, there is a classical called tram track appearance of double glomerular basement membrane, which is also seen. And in lupus nephritis, there is a classical mesangial proliferation along with the MPGN like manifestation based on the class of lupus nephritis. So both of the pathologies are easily differentiable on a kidney biopsy as well.
So the amount of proteinuria, would it tell us anything? It was not a glomerular range proteinuria. It was only a tubular interstitial, right?
Yes. So,
Does that
based on literature, sir, both Tafro syndrome as well as lupus nephritis can present in any of the proteinuria range. It can even be nephrotic range proteinuria in both of the syndromes, and as well as whether it can also be a tubular or a
tubular
nephritic range
interstitial? So you
proteinuria.
don't
So
have.
that does not help
Sure.
us.
So both are possible. The other
Also,
question I had
presence of
was,
RBC cast being there in the urine for active sediment indicates a presence of glomerulonephritis being present.
okay. The other question I had was, could this have an inclination towards inborn error of immunodeficiency? I mean, immunodeficiency type. Now you call it inborn error of inflammation, right? Yeah, inborn error was immunity. So could that have been an anchoring here?
Yeah. So, sir, thank you for those questions. So, coming to your IEM on inborn error of immunity question, I think we are increasingly recognizing a lot of IEMs actually presenting in the adolescent age as their first manifestation with autoimmune manifestation. So in events, particularly, we would always rule out a CVID, and so in this case also, and at least a immunoglobulin profile was done, and the flow cytometry they had done the lymphocyte subset. So the immunoglobulins were actually in the normal range. But I would, yes, this patient was slightly actually in the third decade of life, but a lot of these patients would actually be coming in the second decade of life. And if they are coming with events and autoimmune manifestations, I think at least CV a basic lymphocyte subset and immunoglobulin profile prior to pulsing them with steroids or IVIG is
Important.
a good
Yeah.
idea. So thanks for bringing that point. So
Was
that's
an NGS clinical exome, anything was sent?
Yes, sir. NGS was done for this
uh,
patient, and it showed no pathogenic variant being identified. That's what
Okay.
favored not a diagnosis of primary myelofibrosis. It was excluded based on that only.
So we do. So there are so many. So again, NGS for the listeners. It all depends on what is your panel of NGS. So like at our center, we have a separate NGS for a PID panel, and the NGS what Dr. Naman is talking about is a myeloid mutation panel,
Myeloid,
which was
myeloid.
done as a auto kind of our lab would if they get reticulin fibrosis,
Fibrosis.
it would automatically
Yeah,
send
sure.
sample. So I think on follow-up still a germline CVID or a CID can be considered in this case. So that's one thing. The other thing is that so TAFRO has its own major and minor criteria which are described, and this patient actually fulfilled those criteria. And the lymph node histopathology is actually a minor criteria in what it has been described in the latest version. So that is one thing, and we have to understand this, that this TAFRO, Castleman, and whether it is unicentric or multicentric, these are all spectrum disorders with overlapping manifestations. So TAFRO can be with Castleman or it can be without Castleman, and the ones which are without Castleman tend to have associations with these autoimmune disorders. Uh, so these are not like very watertight categories, and
Yes.
so that's one thing where what we should understand, rather than compartmentalizing them, that this is SLE and not TEFRO, and this is only TEFRO and not SLE. So it's kind of an overlap, at least on a clinical basis, is what I understand.
Great. Sarthak.
So just one point regarding the diagnostic criteria of Tafro syndrome. Though IL-6 is not in the diagnostic criteria of Tafro syndrome as of now, but predominantly the reason for that is the availability of IL-6, which is not even available in the Western world as an instant tests. But it has been shown that IL-6 levels are almost always elevated in Tafro syndrome and Castleman disease-like phenotype, especially in the milieu of an active inflammation. So absence, normal IL-6 in our case pretty much rules out, I think, an active Tafro syndrome also.
So could a Procal and a CRP done concomitantly could have been a clue for, suppose tomorrow a patient comes like this with high grade fever, CRP high and Procal low could kind of trigger at least the thinking process for the residents who are listening to this talk. ESR, maybe we don't do, but interestingly, CRP is not high, no?
Yes, CRP just
14 to
slightly
18.
high,
Our
not
lab
big.
cutoff is less than 5, so this was
5, yes.
Yeah. But, if you have this high spiking fever patient, you would have expected it sky high. The other comment I want you to tell me is, see, you have seen a magical drop in your protein count in 1 month's time. We
Mm.
generally see SLE related proteinuria, continuing it for almost a few years now. Any comments on that? This quick response to steroid and rituximab.
So one thing is I would like to recheck that value. That's one thing, because proteinuria on an outpatient basis, there can be collection
But
issues.
albumin has gone up, no? So albumin from
Yeah,
1.75
yeah,
is
yeah.
right up to 3.7. Yeah.
Yeah, and obviously there's some component of recovery as well. I would say, I don't know whether I mean, I have an explanation that maybe so this SLE, lupus nephritis, has its class 3, class 4, class 5.
Long term. Yeah.
Then maybe depends on that.
Also, I would like to add a point, like if the patient is having lupus nephritis, so the treatment goes like rituximab is also one standard of treatment for the lupus nephritis. Also, pulse patient should be done in a patient with suspected lupus nephritis, and HCQ should be given. Considering these agents, however, proteinuria should not decline that rapidly usually, but considering this as a treatment standard for underlying lupus nephritis, it shows that patient is a case of SLE with which has responded to the underlying treatment of anti-B B28 therapies and responded quickly, that though not expected
This
and
is
being
too
not
good to
expected
be
right.
true. It is too good to be true at this point. Like Aryan said, he would want to recheck it again.
Mm.
But the albumin going up is good. Maybe the entire phenomenon, it's new to us also. It is not that we have seen no many. I have not seen a tafro. Maybe we never recognized it. It is tafro. But if at all there is a proteinuria, we would probably see it lingering on for a while. So, other question I had, Aryan, was you would have taken the neuromatology consult here, probably cross consultation.
Mhm.
How would they want to schedule the rituximab now? Generally, they go once in 6 months and then keep the steroid on a low dose steroid 510, and then add on HCQ versus MMF if they want to bring in. How do you want to you know keep that immunosuppression going.
Yeah, so they usually are more fond of that 1 gram regime which is there, which
Correct.
every 15 days. But we as ITP typically use that weekly 375 mg per meter square. So we had actually
Two scalps of
started
that.
that regime, so we kind of continued that. But yeah, I think she would probably be transition to a azathioprine or a MMF kind of a agent in this case. So
Subsequently. So rituximab, you gave 4 doses only, right? Now,
yes, yes, and those too we
Prometheus.
had to arrange from a lot of. So there were again there were
Finances wise.
kind
No,
of.
no, I agree. See, these are all nuances which we need to fine tune along the way. Classically, you would have 375, would have got 700, 800, and the nephrology, I mean, the rheumatologist would have given a 1 gram.
Mm,
Initially, maybe 15 days, and after that, it goes to an yearly dosing.
yeah.
And then switch on to an ASA. Now, kidney involved first, I do not know. Generally, they say if it is lung, they would want MMF there, and if it is kidney, Retux there.
Yeah.
And was there a lung involvement here at all? Pleural effusion was there.
Yeah,
That's
yeah,
part of
yeah.
inflammation.
Pleural
Was
effusion was
parenchyma
there.
involved?
Parenchyma was not involved.
So there was no ILD. Okay.
In
And
fact,
pleural effusion
even
also disappeared.
cyclophosphamide, they are very the Eurolupus and the NIH regime is something which they are fond of. But this was a young female, and I mean, I think we even consult the rheumatologist, Dr. Naman? I kind of
Yeah, yeah. We consulted nephrologist.
rheumatologist.
Yeah, yeah. We consulted them. Post the diagnosis being made, we considered. We asked them for their further opinion. They told us to continue with the management and go ahead with rituximab. What being done.
So
Okay.
obviously, there is no standard guidelines for TAFRO, but SLE, they may have some standard, some guidance. Dr. Sarthak has raised his hand. Any comments, Dr. Sarthak?
So, sir, regarding the question of maintenance, the maintenance even can be the relapse rates of the SLE are very high, up to 60 to 70% in any form, whether it is a lupus nephritis related relapse or whether it is a skin or a mucocutaneous relapse. So, most of the centers would usually prefer a maintenance, whether rituximab or a second line agent such as azathioprine or MMF. But in a case to case basis, if provided the cytopenias have completely reversed and the renal damage which has also reversed in like in this case, even we can also go for a close clinical watch and add maintenance agent when the relapse scenario occurs. There is no standard approach for this as of now.
Yeah, so when you look back, looks like, some inflammatory process was triggered off in her life, whether it's infection, drug, we don't know, which has kind of taken a spiraling path, and you kind of blocked that with an immunosuppression. Like Dr. Arid was saying, it's a spectrum. We can't say it is in one pocket, we cannot box them in. So I guess it was very interesting and helpful because these are some of the challenges we have to solve in the OPD. In the IP, it is still easier to get resolved, but OPD sometimes things can be really tough, and if they don't get admitted. So I am not seeing any chats in the chat, I mean, comments in the chat box. There are about 89, 90 people here. Any other thoughts you want to say? Okay, in clinical point of view, can you go back to, I mean, since we have about 10 more minutes to go, can you go back to your clinical part and get some discussion on that with Arihan, the clinical findings? So, at the end of history and examination, what would you have normally kept as a differential? We're going back a bit. So we after finishing all the investigations, at this point, what all could have been a good differential, Dr. Arihat?
So, again, one thing which, as particularly, are if there are medicine folks as well, one thing which I would always suggest is that whenever you have anemia and thrombocytopenia in an autoimmune background, before thinking of ITP, TTP is one which should not be missed. So everything else would sometimes is same. Sometimes the not all patients would end up with a would present with a neurological event. We actually don't want them to present with a neurologic event. So whenever you have anemia and thrombocytopenia, which is parallel, before making a diagnosis of ITP, always ask, particularly if the patient is sick in an emergency and it is an abrupt onset thrombocytopenia, that whether it is ITP or TTP. So that's one thing. Sometimes we tend to forget that schistocyte bit of it. So always LDH and schistocytes is something we should always be ordering. And again, we know that SLE is one disorder which can have TTP as one of the manifestations. The
The
second point,
subcutaneous, sorry, go ahead.
yeah, the second thing is whenever we have, in fact, we do order an APLA workup in almost all our ITP patients. So APLA is often a bystander which is there whenever you have immune cytopenias which are there, and that kind of helps you in particularly in the ITP field. It helps you in kind of choosing your steroid sparing agent. Now currently the fashion is of TPORA agonist, but if you have any evidence of autoimmunity which is there, say anything anything to suggest a SLE or an APLA, I would tend to prefer immunomodulatory drug, say azathioprine or MMF, uh, prior to considering, or even rituximab prior to considering TPORAs. So that's one another point. The third point, what sir was discussing, this is a very common uh, scenario to differentiate SLE flare with infection. And does Procal vis-a-vis CRP help here? And at least our rheumatologists say that they have done big analysis, and they say that, those are not very good markers, and they either of them can go either way. So again, we have to before interpreting procalcitonin values and pumping the patient with antibiotics, we need to be slightly careful about it.
So the question I had was the subcutaneous methotrexate. How often are you all seeing that or giving it in any setup?
So that's, in fact, that's the question we also had in mind. It's known, and this was from an outside hematology
Yeah.
practitioner.
So
But
rheumatologists do use that, but I know as a hematologist, we have not yet used that point. So considering all this pathophysiology you just mentioned, thalidomide would be a good savior here if anything else cannot be done, because that has got immunomodulation, anti-inflammatory. And in the past, myelofibrosis, whatever, if you had started thalpred, you would have, you would have responded as well. Maybe if the finances are tight, thalidomide may be a reasonable choice to continue, except, I mean, it's just you got to give him with the aspirin or something.
in
And
fact,
next slide, can you just show me? Sorry.
in fact, this patient actually was started thalpred on day one or day two, and then we decided when on the
Shifted.
next day on rounds that okay, we'll pulse her.
Long term, long term, long term. Long term, he might just do well if Ritux cannot be given. Maybe when you stop, if he has a flare. Just a thought only.
Yes.
And, next slide. I mean, there was no cardiac issues here. Your EF is good.
No, yeah, underlying
120
her 2
pulse.
echo was normal. No
Okay,
pulmonary
great.
hypertension, no valvular regurgitations, nothing.
So
Ejection fraction was
myocarditis
normal.
is one thing which sometimes comes hand in hand with all these things. So that's also, particularly when there are effusions, that's one thing which SLE myocarditis or autoimmune myocarditis is something which we should be on the lookout for. I totally agree to that. The
Right.
second thing is because we do have a number of immunomodulatory agents with us, and like the choice of what to give in a given patient also requires some bit of kind of thought process. Like, this patient is a young female and was yet to complete her family, so we should be very careful before prescribing MMF to her, and probably even thalidomide is one drug we have to be sure about the
Absolutely.
consumption for both these
Good.
drugs. Azathioprine, cyclosporin still safe, but MMF and uh, thal, you have to be very careful. One has to be very careful.
Okay, so I think the hunger calls, and we are reasonably on time, 7:53. Any other important things to share from Naman or Sarthak before we wind up and hand over back to your team?
Sir, just one thing. Sir, like just one learning point which can be seen from this case is like we before labeling a patient as primary myelofibrosis, just because primary myelofibrosis, even if this patient had mild splenomegaly, this patient could have been labeled as primary myelofibrosis. But we before labeling as primary myelofibrosis, we need to look at the megakaryocytic morphology and the leukoerythroblastous picture very carefully.
Right. Thank you so much. Thank you so much, Dr. Naman and Dr. Sarthak and Dr. Harian, for this fruitful discussion. I learned much in this discussion. Thank you so much. And I'm sure the audience would have heard and learned many as much. And I will hand over to Dr. Ms. Deeksha for the concluding remarks.
Thank you so much, sir. So, as we conclude today's session, we thank our brilliant team from PGI Chandigarh, Dr. Naman, Dr. Sarthak, and Dr. Arihant for their engaging presentation and detailed discussion. A heartfelt thanks to our course directors, Dr. Biju George and Dr. M. Joseph John, for their unwavering mentorship and dedication to academic excellence. Your vision continues to inspire young hematologists across the nation. To all our viewers, thank you for joining us once again in this academic journey. Your participation and enthusiasm make Blood the Life Savior a truly national movement of learning and collaboration. We'll meet again in episode 11 as we continue to explore our new frontiers in hematology. Until then, stay curious, stay compassionate, and keep saving lives. Thank you so much and good evening. Thank you, sir.
Thank you. Bye. Have a good
Thank you
day.
for your inputs. We learned.
Thank you so much, sir.
Bye.